3, 2, 1. Liftoff.
Welcome back to the Ketamine Startup Podcast. This is where we talk about how to start up a ketamine infusion clinic, marketing, and much more. In today's episode, I had the pleasure of interviewing Dr. Sara Herman. Dr. Herman is the founder of Reboot Wellness in Silicon Valley in Northern California. We had a ton of fun talking about venture capital, scalability of ketamine therapy, and even touched on stellate ganglion blocks. I had a wonderful time during this conversation, and I hope you do as well. Let's dive right into the episode. Welcome to the Ketamine Startup Podcast. It is your host here, Sam Coe, and I'm very excited for our guest today, Dr. Sara Herman from Soft Reboot Wellness. Thank you so much for joining us, Sara. And for those listeners who may not be familiar with you or know about you, tell us, who are you?
First of all, thanks so much for having me. This is great fun. I am a ketamine therapy practitioner in the Bay Area by way of anesthesiology. I started my practice in 2020 amidst the pandemic, and I was doing open heart anesthesia, among other anesthesia practices prior to. I was out of training for 10 years in private practice, cardiac fellowship prior to. And yeah, I have long time experience with psychedelics. And it was, for people that know me personally, it was a natural transition.
Yeah. So before you actually opened up in the pandemic, what was your career like prior to opening up your practice?
Yeah, I was a busy private practice anesthesiologist. So I was doing all my own cases, mostly cardiothoracic surgical cases, but also busy labor and delivery department, cath lab, general surgery, orthopedics, you name it, we did it, working on that. Yeah.
Yeah. And I'm also curious because I know you did your residency and med school, I believe, in Harvard. Is that correct?
I did my medical school at Columbia, and I did my residency in Boston at Harvard, at Brigham and Women's Hospital.
And I want to rewind even before that. What were you like as a kid growing up?
I was a character. Yeah. So I'm an only child. So and my mom was an operating room nurse. My dad was an anesthesiologist, and they were always working. So I was always looking for someone to play with. So I was running around the neighborhood, doing all the things. I played a lot of sports. I played field hockey growing up through college. Actually, I played in college as well. And I played a lot of Nintendo. I was gonna throw up my little hobby that people wouldn't know about, is my ability to play Nintendo with my toes.
Oh, wow. With your toes?
Yeah.
I remember when I was a kid, I remember having was it the original NES or like Super Nintendo?
Super Nintendo, because we would play. So my parents got divorced, and then my stepsister and I are basically the same age, and we got too good with our fingers and playing Mario Kart. So we would have to move up a level, and we would play with our toes.
Oh my goodness, that's hilarious. It'd be hilarious if you start doing your IV placement with your toes just to take it to the next level.
Yeah, man. They're talented.
That's very cool. All right. Okay. Little fun fact about Sara.
Yeah.
You were at a busy practice. You were doing OB cases, anesthesiology. And what was the moment when you're like, hey, this is something that I'm very curious about, and I'm actually going to take the leap? And
I was someone who was giving ketamine to every patient, period, before, for many years. In fact, the moniker in the operating room for me was the ketamine queen. I like to tell a story of a 90-something-year-old man who was getting a carotid repair, and we would put in arterial blood pressure monitors before, and I gave everyone ketamine for sedation, and I give it to him, and it wasn't labeled because literally I was the only person using it always. And the guy goes, "Did you just give me ketamine?" I looked at him, I was like, "Yeah." And he goes, "I thought so." And I go, "Oh, how did you know?" He's like, "I used to do it." I was like, "Yeah, I guess you did." Turns out the patient was a PhD in pharmacology from UCSF and a rugby player, and so had been very versed in recreational medicine, we'll say. And I said, "Was this a good idea?" And he said, "Yes." And I thought, okay, cool. But I was giving it to everyone anyway as more of a pain adjuvant to reduce the amount of opioids intraoperatively. Probably in 2004, I asked my boss or 15, maybe 14 or 15. I asked the boss at the time, because we also do a lot of, at that hospital, we did a lot of ECT. And with all the ECTs, we would use ketamine when they got rid of the short-acting anesthetic agent, that we would give prior. And so we ended up using ketamine as the anesthetic for the ECT procedures. And so, that there was a Taming the Ketamine Tiger was on the cover of Anesthesiology journal one of these years. And so it was, it was becoming a thing to give for indications outside of anesthesia. And I said to the boss, I said, hey, we should look into this and open ketamine clinic. And he was like, no, which was, luckily for me, it was good, because he was a boss that would have ruined, it would have been done wrong, truthfully. And whatever, I forgot, but I still was giving everyone ketamine because it's a great medicine, obviously. And then 2020 happened, and I don't know if you were still working in the ER in 2020, but who's working in person but ER doctors and anesthesiologists? And our anesthesia group had been bought and sold and bought and sold and bought and sold. And so the current owners were KKR, which is a private equity firm. And what did they do but cut our salary by 50%? And they were getting all of the relief packages, and they were screwing the doctors that were actually working. And so I was getting angry, as was everyone else. And then I started doing a lot of meditating, and I started doing breath work. And in the breath work journeys, and it's interesting because a woman that I work with now who does breath work integration for my clients, she had been part of a breathwork studio that had just opened probably March 10th, 2020 in San Francisco, that's a good 30-minute drive from where I am. And I thought to myself, I'm not going to some woo-woo breathing thing in the city. But then when COVID happened, everything was virtual. I thought, okay, no one's going to see me. I can do this, whatever this thing is, and I can check it out and see. And I started doing the breath work, and the breath work was completely transformational and bananas. But as part of the breath work, what kept coming up was ketamine clinic. Ketamine clinic. Maybe I should listen to the messages I'm getting. And that's when I had a lot of personal experience with other psychedelics. I had never tried ketamine myself. And so I thought I should probably go see what this ketamine thing is. And so I went to a local IV clinic and got a ketamine infusion and thought to myself, oh boy, this is not done well. I could do this way better. And so that's where the starting of my practice happened. And then I went to the ASKP conference that year and was talking to other practitioners. And I was like, oh my gosh, these are my people. Everyone's so nice. They're so open. Everyone talks, they share. It's not competitive. Everyone is realizing that this medicine is great and it helps people. And there's so many people that can be helped, and everyone will share. And so just started going down that road. And I started with a sublet in a small psychiatry office and just grew it from there, because I wanted to really see, was this something? So originally I was literally working full-time in the operating room, and then I would do ketamine for folks post-call, weekends, nights. And I got to a point where I had to choose, and my new boss at the time was more a friend, and so he was totally fine with me. He was like, yeah, go try, Herman, thinking that I would be back. And that was 3 years ago. So,
wow. So it sounds like you kept the overhead very low when you first started.
Yes.
Hey, is this thing even going to work?
That's right.
Then you actually fully transitioned out of anesthesia practice into your clinic, Soft Reboot.
That's correct. That's exactly right. And that's the way to do it, is really start with the lowest amount of overhead possible. My rent at the time was $1,000. So exactly. So if I don't have any patients, it's not that big a deal. So that's
same thing for me. I was using ketamine all the time in the ER. They called me ketamine coke, just how much ketamine I was using for the patients. And my first clinic was super small. I think it was like 700 square feet.
Yeah.
It was 2 offices. I think the rent was like, I don't know, 1,050 or something.
Yeah. Amazing.
And it was the overhead. I think that took the pressure off, because even if I was like, not a lot of patients this month, all good, the overhead is super low. So it was very sustainable.
Yes, that's right. That's exactly right.
Yeah. And you did have your own personal ketamine experience, and you mentioned you're like, man, I could do this way better. And one of the things that I've noticed about you and your practice is you seem to be paying really conscious attention to the set and the setting. So
That's right.
tell us about that, about what do you do to optimize that, and maybe some of the experiences that you've also personally had and how you intertwine it into your
Yeah.
practice.
Yeah. So I just always thought music, first of all, is a huge piece for any psychedelic journey. And so really curating music for the arc of both the individual session and the arc of the client journey over weeks or session to session is really important. I try to make things feel very organic in the office. You have a bad view of one of my little offices, like where my desk is and such. So it's not as one of my favorite rooms, but there's a lot of plants and it feels lots homey, and it has some elements of design that I've just picked up from here, there, everywhere, just traveling in outside of the country, usually for most of the things that I've just tchotchkes and lots of third eyes everywhere because I just resonate with the third eye. And so I just follow my own gut instincts for what I think is going to feel right for people. I think one of the biggest issues with my personal ketamine journey was the lack of eye mask. There was no eye mask. There was no music. The doctor was talking about politics and COVID, and it was really awkward. He was asking me while I was on the infusion, how many sessions can he charge my card for? It was just really weird. Yeah, it was super weird and uncomfortable. And I just kept thinking to myself, yeah, if I need to rip out this IV, I know where I'm running. Yeah, so it just didn't feel safe, I was watching the doctor more than I was paying attention to what was happening. And so I think that building the trust and safety in the container is probably the biggest piece in creating a center or a sanctuary, if you will, for people to journey because they need to feel really safe and held.
And I've seen pictures of your office. I've checked out your website and it looks beautiful. And I'm
Thank
like,
you.
wow, the way you've set it up. And I think there was like, I don't know whether it was like some sort of soft fur. I don't know, but it just looked very inviting. Very.
Oh, you were looking in the vibroacoustic room. So I have a sound lounge. I don't know if you at MAPS or anywhere else, if you've sat on one of those vibroacoustic.
Opus?
I have an Opus, but that one is in Harmony sound lounge. I don't know if Craig James uses the In Harmonies, but yeah. So the In Harmony, I have an Opus, and the tech on that thing is amazing, but it's not as comfortable.
Okay, good to know.
Yeah.
We just use these zero gravity recliner chairs.
Love that.
What is the brand? Cosia, but they do have a heater function and like a massager, which a lot of people don't like because it's too much stimulation.
Yes.
But yeah, that set and setting is very crucial. And one of the other things that stands out is that you seem to have a very intentional practice.
Yeah.
So tell us about your intention and how that came to be.
It's just with any meditation, breath work, life, really now at this point, everything has become intentional. The more mindfulness an individual can get into any practice, really, the more meaningful it seems that event or experience or whatever XYZ you're talking about becomes. And so as far as the intentions behind each ketamine journey, we really ask people to do some thinking before being the day before, the week before. I send them, I made a little workbook, and I send them a little workbook that they can get some ideas and what that means as far as intentionality. We also don't want people to be so stuck on intentions. But I do think about every single piece of the experience, and I want individuals to also get into the habit of being mindful about everything that they do, whether that's how they experience emotions, how they take a breath before they respond, how they just experience the five senses. And so the intentionality goes beyond just sending an intention so to speak, but also just being really mindful, noticing. It's really paying attention to everything really.
Yeah, that's beautiful. For our clinic here in Reset Ketamine, we always have the patients set the intention before any infusion because I agree with you. It's such a critical component. I remember I had one patient and they were at a different ketamine clinic, and apparently they were just like on their phone scrolling through Facebook
Yes.
during their infusion. And you had mentioned eye shades and music. And I think that also plays a critical role in the experience. I was thinking about this word insane. And it comes from the Greek word, two Greek words. In and sonos means sound, and in means without. To be insane is to be without sound.
Okay, that makes a lot of sense.
And the music piece, it's so crucial. And I found this like really old article, I think it was from like the 70s or 60s. And they did a comparison study where they gave people ketamine in the OR and with music and without music. And then the people who received ketamine with the music, they had a much better experience than without the music.
So they were asleep, or it was just like
they were getting a surgical procedure.
Oh wow!
And they actually, in this study, they gave the patients the opportunity to select their own music.
Yeah.
And they found that the ones who received the music, they had a much better experience than the ones who did not receive.
I believe it. It's funny. The last patient I had in the operating room before I left was someone who was having a big thoracic procedure, and they had gone down to interventional radiology and been marked, and down there they had given this person a lot of sedation. So they were very sedated and out of it when they came back to the OR. Now, we used to call our patients the night before, so you get history. And this person sounded very straightforward. I met them in pre-op before they went to IR to get marked. They were sober, said nothing. They come into the operating room, and I was like, oh, what kind of music do you like to listen to? And they say, electronic. And I go, oh, good, you get my ketamine playlist under my breath. And she goes, I do ketamine. What? tell me more. And she's, oh yeah, I do ketamine therapy. And I go, okay, this probably would have been something for me to know, considering you're having a really big surgery.
Wow.
And so then I said, where do you get your ketamine therapy? And they told me, and I know that practice, and I know that they give a lot of home ketamine. And had I not asked about the music, that's the long story short here. The music was the key precipitator for understanding that this person does a lot of ketamine, but the music was so integral in her ketamine therapy that we just kept talking about it and this and that, and we came up with the perfect playlist for her. But it shocked me that she wasn't going to, which is something that people that are doing ketamine therapy, I always let my patients know. It's, if you're doing ketamine therapy and you're having a surgical procedure, you need to let the anesthesiologist know, because number one, they'll probably give you ketamine. And number two, it can affect, truthfully, your pain, the amount of medicine you need for pain management. And so this girl, if she hadn't told me, I'm thinking to myself, oh my goodness, you would have been very underdosed, my friend.
Yes. Yeah. Sometimes I'll see, and I've been out of the ER since 2020, but I'll ask some patients like, hey, what medical issues do you have? And what surgical issues? They're like, nothing. And then I look in their medical records and the EMR, and it's 20 different medications, and they've had a bypass. Exactly. And I'm like, why did you not mention this? They said, I didn't mention it because it's already taken care of. I'm like, no, you need to know some of this information in your background. So I'm curious, you have a successful practice. What's some of the challenges that you faced in either when you first started up the clinic or even to the present day? What are some of the challenges that you have?
You know that you don't have an MBA, do you? I don't know, but I don't.
Yes.
And so they don't teach business in medical school. And so learning how to do all the non-medical pieces felt, and still does at times feel, I don't want to say overwhelming, but a lot. It's just, usually we're used to taking care of the person, dealing with all of the patient aspects. But then on top of that, you're doing marketing, or at least me, office management, marketing, all the business aspects, really everything. And what I've learned is the less number of employees you have, the less overhead you have. So I just do everything. I have one employee. I have the other folks that work with me are more contractors basically. And so I basically do everything myself.
Yeah, that's one of the surprising things. I agree. In med school, residency, like we're not taught the business side of healthcare. And it's so strange that we're not taught this. And I think the AMA released a study saying that the vast majority of physicians are employees rather than owners of their own practices. And maybe it's because we don't have that business background.
That's right.
And like you mentioned, like we wear a lot of hats. Like we're HR, we're office manager, and because overhead walks on two legs. There's this classic saying. It's like, any additional person I hire, it's going to increase my overhead.
That's right. The other thing I would say is it's annoying because you are off all those hats dealing with cancellation policy and want to really be there for the patient and understand X, Y, and Z reason why they're late or they decided last minute they can't go. But at the same time, when you're a small business, I don't want to charge you a cancellation fee. And so then it gets awkward sometimes when you're dealing with these financial aspects that, or at least in the operating room, I never had to deal with those before because it was always like, I don't know, ask your insurance. Like, I have nothing to do with this. But now it's all like, I'm the owner, I'm the doctor. It's like my discretion. Do I want to enforce the everything?
I can totally relate to that. Yeah. Because at our clinic, we have a 50% cancellation policy.
Yeah, me too.
Where if they don't show up, but I always give people, I call it a mulligan.
Yes.
From golf. It's, everyone gets one mulligan for X, Y, and Z.
Yes.
But after the second, third, I do charge them the fee. Yeah. But it is interesting, this dichotomy of being both the owner and the doctor. Yes. And when I was working in the ER, like I never dealt with any of that stuff at all. Like, how do I order gauze and a bandage and meds and hey, I have this person in my staff, I need to talk with them. Definitely wearing a lot of hats.
Yes. And the talking to the person, because at least for me, I love everyone that I work with. And so I'm also really bad at confrontation. It's not even like confrontation, but if there's something wrong, it's really a growth edge to be able to address things in a calm manner and still keep the friendship. It's hard. It's a different thing that I'm used to dealing with.
Could you ever see yourself going back to the OR? And because I almost feel like, in a way, as a metaphor, it was like a lion. When I had my job, I was a lion. I was at the zoo. I was getting fed regularly, the steaks and whatever. But now that I'm my own practice owner, now I'm out in the field. I'm out in the savannah. Yeah. And it's hard sometimes, but for me, I don't really see myself going back. So what are your thoughts on this?
I like the work. And I feel like the operating room work is probably a little different than the ER work because we don't see people. You see them for 5 minutes, you make a deep connection, and then you never talk to them again, which in many ways is nice. But at the same time, it's interesting. When I was in medical school, actually, I applied in derm and anesthesia. And so I had 12 derm interviews and I had 2 anesthesia interviews. And so when I was making my rank list, I was like, I don't know. I don't think I want a clinic. I want to be able to pick up and go. I want shift work. And so I went into anesthesia because of those ease of just whatever I can do it when I want to do, when I want to do it, where I want to do it. You don't need that clinic base. But then I started to feel like I would like to know the patients a little better. So the tables turned a little bit. And now that I'm in the place with the clinic, I'm like, I do miss when the patients don't talk sometimes, truthfully. But at the same time, I love being with the patients. I love seeing how they improve. But there are benefits to anesthesia, although the politics in the hospital I'm so through with, and I cannot, unless I can't afford to do this anymore, I cannot go back to that lifestyle.
Totally. Yeah. And the work of being a ketamine clinic specialist and owner, in a way, it's like it's a labor of love.
Yes.
As trite as that sounds, it's not like this thing where financially I'm making huge amounts. No, this is a lot of work because I don't know about you, but even when I'm not at the clinic, I'm still thinking about the clinic.
That's right.
And it's like having a child in a way. I'm always thinking about it.
For sure.
It's
Well, because you're trying to
patient
improve
perspective.
it, you're thinking about patients that are doing poorly, or like how you get more patients, what about this playlist? Can we make something new? You're doing a lot of social media, so I'm sure you're always doing more filming and that kind of thing, which I'm trying to make myself do, but I can't. I'm like, no, it's too much work. It's a lot of work. But yeah, and people think they're, especially in Menlo Park, my infusion prices are high. It's $850 a session. And people are like, some folks will make comments, or they don't really make them anymore, but some patients would make comments about how expensive it was. And I'm like, guys, I took a $400,000 pay cut to do this. I'm not making a lot of money. The rent here is really high. Yeah, it's not because I want to charge you. And if you think about it, per hour as a doctor with all these credentials, I'm really $400 an hour. By the time the credit card companies take away like whatever it is, 3%, 3.5%, I'm like, I'm not making that much.
Sure. And plus the fact is, even though it might be $400 an hour, you still have that overhead and insurance and supply, staff, et cetera. So it ends up being less. I have a buddy of mine. He's an attorney.
Yeah.
And I was talking with him about pricing. I'm like, I've kept my prices the same for a couple of years. And I'm like, I feel like I should increase it.
Yeah.
And we were talking and he's, Sam, just to let you know, I charge $1,000 per hour.
Attorneys charge so much money. I know.
And so I was like, oh, he charges $1,000 an hour just for his kind of legal brain. And I'm like, okay, I think it's reasonable to charge a fair rate, especially because people are taking a pay cut to do what they're doing.
Yeah.
On the ketamine side.
For sure. The other thing is primary care and psychiatrists are charging per hour $650, something. The other doctor that works with me, she usually does most of the new consultations, just because I sit with every patient myself, so I can see 4 people on it. So 8 hours is enough work for me. So she'll do the new consults and we're only charging $300. We need to charge more. Primary care hour is $400 and they don't even do anything. I'm like, oh, it's just the finances are insane for what the other specialists are charging. And even therapists charge $300, $350, $400 an hour. So
totally. And speaking of charging, I do want to touch upon kind of the insurance side.
Yeah.
So I know that you're partnered with Anesthesia.
Yeah.
And so tell me more about that.
We haven't gotten any folks from them yet, so I can't tell you. We've done all the paperwork and the credentialing, and we are up to date on how to submit the requests, etc. But I'm not. We haven't gotten anyone yet, so I can't tell you much.
Yeah, I started the process, and it's a lot of paperwork and CPT codes, and oh man, I hate personally. I think I mentioned this to you before, but I hate doing paperwork, so I've been putting that on the back burner.
Yeah.
But for those listeners who don't know, Anesthesia is a kind of a niche insurance company where they're really targeting psychedelics. I think they work with Dr. Bronner's as their main company right now. And they had mentioned to me that Dr. Bronner's I think their headquarters is in San Diego. So I'm like, I'm in Palm Springs, that's fairly close. So maybe if I go down that process, I'll get some people from San Diego who come. What about like super bills and reimbursements? Are you doing any of that?
So do you use Osmind? Yeah, so we use Osmind as well. And we've been giving folks super bills through them. I would say, especially in the Bay Area, most folks have decent insurance. So we see people getting reimbursed. Really, some folks, the Apples and the Googles and the YouTubes and everyone else, they get back a pretty decent, sometimes half or more.
Yeah, I had the same exact thing happen. We had someone who worked for one of these, I think their partner worked for one of these large companies from Silicon Valley, and they were getting 50, 55% reimbursement.
Right. Yeah.
Interestingly, I had another patient who got 100% reimbursement.
Oh, wow.
Every ketamine therapy.
And wow. What kind of insurance did they have?
She had something called, I think, FirstNet or HealthNet.
Oh,
but
wow.
Apparently it was a lot of back and forth where she was arguing and sending in appeals and talking on the phone for hours, being on hold, going through the phone tree. But eventually she ended up getting 100% reimbursement. So that was kind of good to see. There's a lot of work.
Yeah, the perseverance. I have a patient who started working with me when she was 18 or 19. So her mom was doing all the paperwork, and her mom has a lot of experience in dealing with the insurance companies, to the point where I guess if you persevere enough, you get into some group that's like VIP and somehow she got in touch with the C-suite for this insurance company, and then now everything that she submits is paid for.
That's so awesome. I really think insurance companies obviously should cover IV ketamine therapy because it would actually save them money in the long run.
That's
And
right.
there was that one recent publication in the New England Journal of Medicine comparing ECT versus ketamine for treatment-resistant depression. They found it was just as efficacious, maybe even slightly more efficacious than electroconvulsive therapy.
With less side effects.
With less side effects, exactly. So I think I'm hopeful that the insurance companies will say, hey,
Well, no, they just put ketamine as first line for treatment-resistant depression.
Absolutely. And so if they really look at the scientific data and the evidence, they'll say, hey, this is not only good for the patients, but it's actually even probably more profitable for the insurance company to cover IV ketamine.
What I heard is that they have AI doing the reading of the super bills. And so that's why frequently they will refuse first time, that it's not actually a human that's reviewing the submissions.
God, it's just like an automatic initial denial. Yeah. And I think I had that happen for me personally. I had some high cholesterol. And so the physician, my primary, was like, hey, let's order a CT scan. I asked him to order a CT scan for a cardiac calcification.
Yeah.
And he submitted it. And the insurance company said, nope, we're not going to cover this. It's not indicated. And I was like, man, I don't want to go through this whole, again, paperwork, not a fan. So I just ended up paying out of pocket. And it was not that expensive. It was a couple $100. I'm like, okay, cool.
Yeah.
And so I'm pending, but it does happen, whether it's IV ketamine or just insurance companies, they just
they're paying.
Save their money.
That's right. It's not a good system, that's for sure. It's something that needs to change.
And now a quick word for our aspiring ketamine clinic founders out there. If you've tuned into our episode today, chances are you're curious about the ins and outs of starting up a ketamine clinic. It's an exciting field, but let's face it, the journey from idea to actually opening day can be quite daunting. That's why we've created something special for you. Think of it as your personal roadmap, a free downloadable checklist that lays out the essential steps you need to consider when starting up your own ketamine clinic. This checklist is designed to help you avoid common pitfalls and launch your trajectory to success. So how can you get your hands on this checklist? Simple. Just visit www.ketaminestartup.com/checklist and grab your free copy today. We've made it easy and accessible because we believe in supporting our community with valuable resources. Ketaminestartup.com/checklist. All right, let's get back to our discussion. Stay tuned and don't forget to download your free checklist during or after the podcast. I'm curious, tell us, so you've been open since 2020. Are there any patients that stand out? Man, I'm so glad I was able to work with this individual. And tell us about if anyone stands out there and how they're doing post-infusions.
I have one patient that I think about frequently. He came in, he's in his 60s. He tells me that he was in his prime at the Olympic trials for swimming. He was like a second short or a second and a half short of Michael Phelps. His times and the stories this man tells are just unbelievable and incredible. But and actually it was I can't remember, it was his therapist or his psychiatrist who reached out and was basically telling me that this was palliative. And this man is always suicidal. And if he cannot be readmitted, and if the ketamine either worsens suicidal ideation or doesn't work, or his condition worsens, whatever it was, he was not to be readmitted. There was no medicine changes. Literally the ketamine was to be just something to try to make sure that, or just to see. And so the first couple sessions, he would ask literally for potassium chloride for me to put in his IV. And so I would sit there and I would think, no. Now I tell him, I was like, no, I can't give you potassium chloride. But I'm back in my head, I'm like, oh my God, why did I even say yes to this guy?
Oh my goodness.
And now he's out in the world. He has a job, albeit he can't have a super professional job like he used to have for other reasons, but he does work as a lifeguard. He is able to take care of his, activities of daily living. He's doing the things. He's about to move out of his family's house to live by himself. I started seeing him a little over a year ago. I do something called the Stellate Ganglion block as well. So I don't know if you're familiar with that, but he was also a recipient of one of those. And so I think that helped his anxiety a lot along this process. And so, yeah, he's one of the real success stories. And I just remember being like, I'm not giving you potassium chloride. There was another person who I still see who, when I first started seeing her, in the beginning, when I was subletting out of the psychiatry office, I was really getting all the really complicated, really treatment resistant folks because they were all referrals from the psychiatry office because they also had a TMS program. So they would the choices after they failed the TMS were ketamine, ECT, or a lot of them were thinking suicide. So one of the persons that would come, she would just sit there for the first and just be, I just want to, I'm so fit too. Sitting there sweating. I'm like, do I need to admit her? Oh my God, what the heck is happening? And then she'd wake up and she'd take her things off. She'd be like, oh, thanks for letting me do that. No one else lets me say that. And I'm like, oh my God.
Oh, wow.
Yeah. And so she's doing really much better too. But in the beginning,
yeah, that you saved her life. You saved many lives. That's very rewarding. Yeah. And one of the things, just so many things are coming up for me, but during the experience, so for you and me, we do it a little bit differently from some of the other clinics in that we actually monitor the patient's vital signs continuously.
That's true.
And I know some clinics don't or feel like that's not necessary at all. What are your thoughts on this? I know it's controversial in the ketamine space.
So I have a couple things that I think. First of all, I rarely do I ever treat any vital signs. I see them and I'm like, one vital sign that may seem out of it. I think in 3 years, maybe I've treated blood pressure twice, truthfully. As the worst thing, you don't want to overshoot because once the ketamine's over and the blood pressure medicine's still there, it's worse to have the lower blood pressure, right? And for me, and I tell people this, I'm like, this monitoring is more for you to make you feel safe, to know that I'm actually sitting here looking at your vital signs, because I think it becomes that safety and trust and the patient's feeling, oh yeah, this is a doctor. Even though there's two pieces or two sides to that sword, is when they start thinking that, oh, this is a doctor, they know what's best for me, they should be doing it, I listen to the doctor, etc. I do think about that. But truthfully, I think that people like having the monitoring. They like knowing that there's someone watching, especially if they're getting deep and it's feeling intense or overwhelming. And then some folks are like, am I okay? Am I dying? Or whatever it is. You can be like, no, you're fine. The only times that I've been really happy that I have them are more for oxygenation, for folks that you wouldn't expect to have sleep apnea or to desaturate. They will occasionally. And so I'm always happy to have a pulse ox to see what's happening there.
100%. I know classically the teaching is, oh, ketamine, it does not suppress the respiratory drive. And in general, that's true. But I have seen where patients, their breathing slows down and they're a little hypopneic and their O2 sats are dropping into maybe the lower 90s. And so my cutoff is around 91, 92. I will put them on little 2 liters nasal cannula. But I think to myself, man, I'm so glad I was monitoring this patient because their O2 sats are dropping and I did not expect it.
That's right. Yeah.
And so it is I do feel like it is the safest way, in my opinion, on how to go about it. Although there are differing thoughts on this.
I completely, because the truth is if you tell people that it's for their safety, it doesn't bother them. They don't mind. I haven't had a single person say that they were annoyed or bothered or the journey was changed by having either a blood pressure or a pulse ox. Never, not a single one.
Yeah, some of my patients like the blood pressure.
Yeah.
When it starts inflating,
the ground
like a cue 10, 15 minutes.
Yeah.
And they're like, oh yeah, when I felt that blood pressure cuff, it reminded me that I was still alive.
Exactly.
It reminded me that I was still here. It felt, they felt like they were an astronaut. And I think one patient said, I felt like you guys were Houston ground control. I knew that I was out there, but I was still tethered.
I love it.
That I was going to be safe.
Yeah. Yeah. I actually used a caretaker model. I don't know if you're familiar with that thing. It's the wireless continuous blood pressure.
I've seen it. Do you like that model?
They tell me that it's used in PACUs and in ICUs, and I have a hard time believing that folks that are in ICUs that actually need their blood pressure taken should be using that. But for ketamine therapy, it's great.
Awesome.
Yeah.
And I am curious. I know this is the Ketamine Startup Podcast, but I am very interested in hearing more about SGBs.
Oh, yeah.
Ganglion blocks. Yeah. Tell us, the audience, what is that? How did you get your training in that? And, what do you do? What's the protocols there?
Yeah. So the stellate ganglion is, the way it's described anyway, is basically a fusion of the two ganglia, T1 and C7, essentially, the sympathetic ganglion. However, what's interesting about the anatomy of the sympathetic chain is that it's very variable from person to person. And essentially, and truthfully, the way this works seems way too good to be true. Basically, by using ropivacaine with the half-life, I don't know, it's like probably 2 to 6 hours, something like this. For the duration of the local anesthetic, it becomes like a on-off switch for the sympathetic nervous system, and you get decreased nerve growth factor, which is involved in norepinephrine release. And for whatever reason, for 2 to 4 hours, without that on, it decreases the sympathetic outflow. And then people's physical experience of fight or flight is reduced. It's also good for long COVID. And so the people with olfactory changes and taste, if you're able to find the right side, I would say that most of the long COVID folks need bilateral blocks. But anyway, they get their smell back immediately. Brain fog is gone. Energy, breathing, all these things return, which is really impressive. As far as how you get your training for it. So the anatomy of the neck, especially for a cardiac anesthesiologist, is very commonplace. I was putting in swans more than once a day. So the ultrasound anatomy with the blood vessels particular was very well known to me. And that being said, we do a lot of regional anesthesia, neck blocks, interscalene blocks for upper extremity surgery, etc., are also quite popular. My husband's also an anesthesiologist, and one of his colleagues is a pain doctor, and he was doing stellate ganglion blocks in his practice. So he actually came and supervised me. I did a lot of YouTube to figure out exactly how, and a lot of anatomy studying, which is super interesting. One of the anesthesia meetings, it was in San Francisco, and one of my attendings who did a lot of regional anesthesia at the Brigham was there, and I was asking him about stellate ganglion blocks, and he was telling me he had been to the anatomy lab and he was looking at all the different paths. And so actually the common practice now is probably it's a dual block. So you do also the superior cervical ganglion at C4. So it's 2 shots, and that's really to account for a lot of anatomical variations and just different branches breaking off, et cetera, at different places. And it's apparently there's only a stellate ganglion in 80% of people. So if it doesn't work, then you go to the other side. But it also seems like most or many practices are just offering bilateral to begin with because there is some sympathetic outflow on the opposite side. So it's been an interesting journey, but it has really been helpful for a lot of folks.
That's so cool. And that's so cool, Sarah, because you're doing it via ultrasound guidance. And I know some other clinicians, they're doing it via fluoroscopy.
Yeah.
And
the problem with fluoroscopy is that you're missing the blood vessels. In fact, James was talking about how he saw someone have paralysis in the fluoroscopy, and it's because the provider was going way too fast. And with fluoroscopy, you just don't see the vasculature.
I think seeing the vasculature under ultrasound is really crucial. I actually I have a small device. It's called the butterfly ultrasound.
Yeah.
And I don't know if you use that for your SGBs, but I use okay. Yeah, I use this butterfly ultrasound for the, is that the Clarius?
It's a V-Scan Air. It's a GE. Awesome. It's impressive. It's as good as the big machines we were using in the OR. And then I can just put it on an iPad. It's pretty impressive.
That's awesome. Yeah. Mine is wired, so it connects to my phone, but I'm able to find, I mainly use it for getting peripheral IVs when they're a challenging, quote, difficult stick. But I'm able to get in these IVs like 99% of the time on the first go. When
That's
you use that
amazing.
ultrasound machine, it's really useful.
I love it.
I guess it's cool that when we were in our residency, like this was a thing
Yeah.
where the ultrasound was just up and coming. They
Yeah,
had
we
the
were
big
lucky.
machines, but the portable one was pretty up and coming when I was in residency.
Yeah, there was definitely no portable. There were those big monsters, which this thing is just as good as them. I've been very pleased with it.
Nice. And thank
Yeah.
you to YouTube.
Yeah, I know. Yeah. And I still, even because I'm not doing 10 a day, right? So I probably do 2 a week, something like this. And so the night before, I'm studying every
Right.
night
And
just to make sure.
and is it like 6? Is it a one-time thing or is it a multiple for the
You start with a one-time to see, because in some people, it's like instantaneous, the amount of relief they get. Really, just the anxiety. I had one person who I'd been seeing her for, I don't know, 2 years of ketamine, and she needed home ketamine, et cetera. She had one block. Haven't seen her since.
Wow.
Yeah. And she told me, she was like, yeah, my daughter says I'm a new mommy. I'm the same mommy, but like I do things now, make decisions, and it just really is a game changer.
Yeah, that's awesome. And I
Yeah.
was reading a study where they were using stellate ganglion blocks for complex regional pain syndrome.
Yeah, those you need more than one. Those are serious for sure.
And I remember in this study, they said that if they respond to the stellate ganglion block, they're more likely to respond to IV ketamine as well. So there was a correlation between that.
Yeah, I believe that. And I think that's related probably to the changes in the vasculature with the catechols and things.
Totally. So what are your patients like? Are you doing a lot of mood disorder, pain disorder combination? I know some clinics just specialize in PTSD, depression, anxiety. Other people are like really into CRPS and migraine and central sensitization. But you sounds like you do.
We do everything. Yeah. Most of the patients, for whatever reason, are mood. Maybe, I don't know why I don't have that many pain folks, but the pain folks that I do have are doing great. Migraines really improve. The CRPS, I have one CRPS person. She does great.
That's awesome.
Yeah.
So during your, I guess now we're in 2024, so you've been in practice for about 4 years.
Yeah.
Is there any moments where you're doing the infusions and you got scared a little bit where you're like,
I told you.
because they say that when someone does this practice long enough, like there's going to be some challenges. And in particular, is there any scary moments when you're like, oh, MG?
Yeah. The one when in the beginning, especially when she was just like, I just want to kill me. I was like, oh my God. The question was like, do I need to admit her? There was another person early on. I made the mistake of letting her, she was actually the same person who had the SGB and I didn't see again, but she was a 40-year-old person, but she wanted her mother there. And it turns out the mother was part of the pathology. And in that case, it was like the patient was contemplating death and was like, oh, I just want to leave and my mom can take care of the babies. And then the patient's crying. The mom is crying. The mom's looking at me. She's, is this normal? I was, oh, this happens all the time. I had no idea because she was probably like my second patient. And then I realized that it is not a good thing to have family or friend, really, because you don't know what the backstory is and whether or not they tell you it's fine. Then you start to realize just how intertwined the mood and the problems usually stem from something at home. And so it's just easier. And I've found that going forward, we just don't allow them. We don't allow other people in the room.
Yeah, same here. I have patients who are like, oh, I want my boyfriend, girlfriend, husband, wife. I'm like, no, it's already a small room. It is, and it's going to be tight, but they can totally wait right inside of the waiting room and they'll be ready to pick you up.
That's right.
But yeah, I think there can be some underlying relationship dynamics that are not necessarily obvious.
That's right. And then the other thing is when especially for family, and they just want their family member to get better. And there's that pressure, even if it's not verbalized, that the patient feels. And so then it just becomes these expectations, and I want this to work for me because they need it to work for me. And it's just cleaner to just not have. So there's been a couple of those. There's been 1 or 2 instances where they were very deep folks. Actually, I had, this was a very memorable patient initially, because I feel like I know all of my folks very well. And so I let my assistant, it was the Wednesday before Thanksgiving, and it was the last client of the day. And so I let my assistant leave early because I was like, oh, I know her. This is an easy person. And this person walked in a completely different manner than I had ever seen them. In fact, they were speaking in a different voice. They had all these tics, and I was, oh shit, what's happening here? And then I was hesitant really to give them ketamine, but part of me just had this intuition that maybe I should just ask them. And I was like, so do you feel like, because they had never shared with me this part of their history, that this was something that happened, and they had actually been to a different psychiatry run clinic, and I had all the records, and there was never mention of this. I was like, oh, she's been cleared by a psychiatrist, she has a therapist. No one had ever said anything about these tics or this altered persona. And I was like, are you sure that you want to do this? She's, oh, I need to do it. So I give her ketamine, and she says, after she's starting to go deep there, she goes, can we come out now? And so I had been doing all this therapy training, and we'd been talking about dissociative identity disorder. And I was like, oh, here we go. I was like, yeah, let them all out. And so I met all these different parts of her, different ages. She had, turns out, like horrible trauma happened to her. And all these different fragments were all just, all the parts were coming out and were interacting. They all had different ages, different names, different like voices. And it was fascinating yet overwhelming because I didn't have anyone else in the clinic with me. And so I didn't know what was going to happen here. But everything went fine. And I still see her to this day. And ketamine's really the only thing that helps her. And so that was a fascinating one. And then there's been some times where people are screaming and crying, and we have the IVs on the floor and they're drumming, and there are situations where, and from now on, I always have another person, because you just, even when you think someone, you may not know them as well as you think. So I learned my lesson the hard way.
Yeah, and it's a lot of learning, and the fact that you were actually taking that course about DID and it showed up and manifested. That's very synchronous.
Yes, and it was very synchronous and very lucky that I had those, or a little bit. And actually, the therapist she was working with had said something that was a little off to me, and I just had it in the back of my head. I was like, oh, that therapist doesn't know what she's talking about. And then this happened. I was like, oh, thank God she said something. So I was literally on my toes when this happened. But it was, I feel like the more you can just stay calm, as soon as you show the tiniest bit of anything, everyone is picking up on that. So that's what I've learned, is even in the situations that feel scary, and not from a medical standpoint, knock on wood, I haven't really had any medical catastrophes or emergencies, and part of that might just be because we are monitoring and sitting and staring at folks. And yeah, more of these just altered experiences that have been interesting. Other than that,
yeah, that's interesting, because Stan Groff talks about, he has a book, it's called Spiritual Emergencies, where it's not necessarily like a medical physiological component, but yeah, there can be some spiritual type of challenges that occur, psychological. Our time is wrapping up, and so I just have a few kind of fun questions, just shift gears for you.
Yeah.
And you've already answered the one about the hidden talent or hobby.
Yes, playing it.
So I'm going to skip that one. Yeah. But let's say, here's one. After a long day at the clinic, let's say you've seen those 4 patients, you're like, man, that's been a long day. What's your go-to way to just relax and de-stress, Sarah?
Yeah. I'm a soul cycler. I don't know if you guys don't have a soul cycle in Palm Springs, do you? But yeah, so it's biking to the beat of music, and less so about crushing yourself with numbers and metrics and heart rates. And it's more about just dancing on the bike that goes nowhere in a dark room with loud music. That really is helpful. I used to walk my dog, but she passed away on New Year's Eve. So that used to be a real de-stressor. But yeah, I go home and I sit there, I have food, let it digest, and then do some exercise. I do all my meditation in the morning, so I feel like I'm grounded. And then just after the day, I'm tired. Need to just sit for a minute and then exercise.
I love it. I love the fact you're able to get motivated to exercise. Sometimes I just want to come home and just chill out, and I'm like, I'm done, and play with my daughter. And just be with her.
Yeah.
Let's see here. Time travel question. If you could go back in time for a day, What time period would you go to and why?
Oh, I was thinking about this. I think that question is supposed to refer to literally stretch like whenever, but I would go back to our 5-year wedding anniversary party in Vegas. So not that long ago, but it was probably one of the best days ever. And I would do it again. And it was super fun. We had, I don't know, like 50 of our friends there. It was magical. And I would do it again. And I know that it's boring. I think I'm not so much a history buff. If you asked my husband, I'm sure he could come up with a bazillion different things and why, but not for me.
I love that. Yeah. Going back to the 5-year wedding anniversary. That's beautiful.
Yeah.
Let's see here. And this was not a question that I had, but I'm going to pull it from one of my favorite interviewers and podcasts that I like listening to. But let's say that you had a billboard.
Yes. Oh boy.
And on that billboard, you could write anything.
Oh no.
What would you write on that billboard?
Am I selling something or is it just more?
Anything that a bunch of people are going to be reading.
I just have to say, trust the process. Because it's true. It's a lot of the times it's confusing, this whole thing we do called life. And it's just really just going with the flow, being present, trusting the process is something and I try to believe myself, but also share with other folks. So I think that'd be on that billboard.
Awesome. Thank you, Sara. And for those listeners, viewers who want to explore you and your background or get to know more about you, what's the best way for them to connect with you? Is it your website, socials?
Probably website. Yeah. As I said, I'm trying to do the socials. I'm just lazy. Awesome. I'd rather be on my bicycle or sitting on the couch doing nothing.
We will link to Dr. Sara Herman's website as well as her LinkedIn and other socials, which she may or may not be on. But,
yes.
You'll still be able to connect with her. And is there any other last thoughts, comments, questions, concerns, complaints?
No.
Before we wrap up and close out?
Yeah, no, I think we've said is like, this is the labor of love. It's just fascinating to me that the whole psychedelic industry is, people are baffled on why these big chains went out of business. And actually, truthfully, people ask me all the time, how can we scale this? How can you scale this? Come on, no, dude, this is hard to scale because it's so much about the provider and the space. And it's hard to find a lot of reliable, grounded folks to sit with people in altered states, truthfully. And that's the bottom line, is that this is not a money grab. It's far from it, if anything.
Yeah, that's so true. I've had, when I first started, like multiple venture capital, private equity, people were like, hey, let's go IPO, blah, blah, blah. We're going to give you shares. And it just didn't feel right to me because this work that we do, it's not like McDonald's. It's not like a scalable thing. And finding the quality people who really have the right intention, the right mindset, the right background, there's not a lot.
That's
They're hard to find. Yeah. Thank you for that reminder.
Yeah.
Thank you so much, Sara. I really appreciate you being on the show. And thank you for doing all the work you're doing. I can really tell that the way you practice your medicine is very powerful and it does stand out. So thank you so much.
Thank you. Appreciate it. Awesome.
Okay. Bye, everyone.
Bye.